In the studio with us tonight to dwell more on the 2017 AIDS Day are Dr. Kema Onu, State Coordinator, AIDS Healthcare Foundation, and Walter Ugwacha, Executive Secretary, Civil Society for HIV and AIDS in Nigeria. Welcome to the studio.
Thank you so much.
Okay, so has the war commemorates World AIDS Day?
So,
Has the war commemorates World AIDS Day? Dr. Kema, what comes to your mind?
Another day, 365 days, when we need to talk more about HIV and AIDS. We need to review the statistics and to see what we've achieved over the last years, and then how best we need to renew our energy in the fight against HIV and AIDS. Just about exactly a year ago, I was on the same platform when we were talking about data. 36.7 million persons living with HIV AIDS worldwide, and 25.6 million of this population are domesticated in Africa, especially sub-Saharan Africa. And even in Nigeria, we have our own share. A large chunk of it, 3.2 million persons. And out of these 3.2 million persons, over just about 800,000 are on antiretroviral drug. If you look at the mathematics, it's like 1 out of every 3 persons with HIV and AIDS in this country has access. So I think this year's theme, Right to Health, making it access, making it happen, it's good, but I'm always in question of slogans.
Oh, okay.
It was getting to zero for almost from 2011 down to 2015, getting to zero in terms of new HIV infections, getting to zero in terms of stigma and discrimination index, getting to zero in terms of reducing AIDS-related deaths. And maybe they got tired of it in 2016. They changed to hands-on for HIV prevention. And this time it is Right to Health, making it happen. I think we should look at these slogans which are used for advertisements.
Okay.
We should go beyond advertisements of what we want to do for HIV and AIDS. We should talk about what is more pragmatic. And that is why this year, why we are joining the goal to say Right to Health, making it happen. I said, let them keep their promise.
All right, thank you.
Yeah.
So he just told me what came to his mind. So what comes to your mind as we're celebrating World AIDS Day today?
Yeah, first is we're not celebrating the World AIDS Day.
Oh,
We're
we're
rather commemorating the
commemorating,
World AIDS Day, and it's a time for sober reflection. First, to remember all who have lost their lives. In Nigeria, we have 210,000 people that die annually as a result of AIDS-related illnesses. So we are standing up for them, giving a 1-minute silence for them first. Then what also comes to our mind is we remember all the fights we've had to fight from the year 2000, when we had the prevalence at 5.8%, where a number of people were rushed on emergency cases to facilities, to 2017, where we've been able, through the help of donors and in the international community, where we've been able to provide treatment, make it free for everyone, although it's no longer free right now. So make it free for everyone to be on treatment, having to have people that were working before go back to their work and be reunited with their families without having necessarily to die. Then what comes to our mind as civil society is also the work we need to do if we must end AIDS. There's need for us to end AIDS. We cannot say no to that.
Definitely.
We
must have to end AIDS, and we have to be committed to doing that. And we have to hold everybody accountable to ending AIDS and push everyone towards that direction. And again, the last thing that comes to our mind is the fact that we need to stop doing the talking and we need to start doing the action now. So as we move in that direction, that's what comes to all of us in mind.
Okay, so now this year's World AIDS Day is the theme is My Right, My Health. Do you think the United Nations have done enough to protect the health of humans globally?
Yeah, yes, fairly enough, to be very fair to them. The WHO has done some, the United Nations have done some very good work in terms of putting the policy framework there, in terms of putting the enabling environment, in terms of asking most governments to remove legal barriers that hinders access. But you know that from country to country, these things vary. For instance, in Nigeria, we have a huge one at that, which was our Same-Sex Prohibition Act. And that to us has kind of put a blockage to providing access to health for everyone, for all the key populations, people, MSM, FS, PSW and all of that. So on the United Nations angle, yes, they have done enough. But at our own country level, even within ourselves, within those that are not key populations, we are still stigmatizing, we are still discriminating, and we are still, our health facilities is not adequate to be able to provide for everyone. So I can't say everyone in Nigeria is written in paper you have right to health. But in practice, you do not have right to health, because most facilities, when you walk in there for basic health services, that's what we're saying. That's what the universal health coverage is all about. For basic health services, it's not there. And you begin to wonder if these things are not there, if it's not being provided for everyone. So what are we talking about when we say right to health? It's your right, but it's somewhere. It's not there. It's not available. So that's what, what comes to mind around that.
All right, so back to you, Dr. Kema. You spoke about antiretroviral drugs. Now, how accessible are they to people living with HIV and AIDS? And then, aside that, how accessible are other treatments for HIV?
Okay, so see this back to data. 3.1 to 3.2 million persons living with HIV in this country. 800,000 above are on treatment. So if you say that, why do we have this gap? Why are persons living with HIV not getting antiretroviral drugs? And the first thing is, one, it might amaze you to know that if not 100% of our antiretroviral drug in this country are imported. We don't produce this to the country. And he will talk more about, it makes no sense, because this will create jobs. This is a disease that is unique to our environment. We can create jobs, we can make it more sustainable to be able to produce these drugs in country. So accessibility. And secondly is that out of the over 800 people still juggle about data over the antiretroviral drugs that you have this year in the country, or people who are antiretroviral drug, more than 750,000 of it are supported by donor.
Okay.
It is not funded in country. For me, it is he who pays the who pays the piper that detects the tone. If the person who is giving you this money tells you tomorrow that you should not do this or you should do that, for me, it's a national security issue, because they are the one funding. So if the donor says, I do not want to fund it again, 750,000 lives over will be hanging. And that is a serious problem. And when I'm saying it's a national security issue, you look at this year's budget and you see that the defense still has more than health. The Nigerian government, in planning to replace a unique commitment and the flag off of the World AIDS Day in the State House, they said they will put 50,000 persons on care every year at the cost. Currently, out of the 35 plus 1 states in the country, the government is taking care of Taraba State and Abia. Taraba data is high, but Abia is low. The rest of the states are purely funded by foreign donors. And I think it is dangerous. I think we need to look for a more sustainable way of ensuring that antiretroviral drugs are available and accessible. It was amazing in the 2016 guideline where we put in new drugs, very wonderful drugs for antiretroviral. We put in new drugs. I can tell you, of the 3 new drugs that we knew that were put in the guideline, we are yet to get one in country. Dolutegravir, Darunavir, they just brought these drugs, they're wonderful drugs in the guideline. 1.5 years after, we are yet to get these drugs. Kenya, small countries like Kenya, Uganda are accessing dolutegravir. It's an amazing thing. Nigeria has one of the largest burdens of HIV in the world. We don't have these drugs. So we are really backward in terms of accessibility. And you should not underplay the benefits of antiretroviral drug. Amongst other benefits, antiretroviral drugs helps our patients' virus to go down, allows their immune system to go up, keep them clinically stable. But the most important benefit is a public health benefit. It reduces the risk of transmission to the next person. So imagine that we had 3.2 million persons on HIV and 3.2 million of them were accessing antiretroviral drug. I can assure you there will be no new infection. And by 2030, most of us will stop talking about HIV in Nigeria. So we need to really get accessibility very, make it available. It was funny also to hear that while we are still having these gaps in drug accessibility, people are talking about pre-exposure prophylaxis. You want to give drugs to people who don't have HIV to prevent them for life, when those who already have drugs are not even accessing it. Good idea, but we should bring these ideas and bring them to support it with the realities on ground.
Okay, so now, would you say that this issue of treatment and antiretroviral drugs not being available is being politicized in Nigeria?
I don't want to say politicize. I want to say that if the government has renewed interest, go away from slogans. I don't like getting to do this, wanting to do this. Don't advertise with health. Don't play politics around health. So we should be able to mean what they say, and that is why we have Susan, who has always been on their neck. We need civil society. We need NEPO. No people who are. They should in the budgetary process. These people should be there. They should question why this budget for health is this way. Are you with the statistics you have? Why should it be? In the budget implementation, the civil society have a major role to play. A major role to play because thousands of lives are at stake. This virus has caused 35 million deaths. And he said every year over 200,000 deaths. Preventable deaths. Highly preventable deaths.
Okay, so you're saying the availability of drugs is not being politicized, or
I think he will be the better person to say that.
do you think it's being politicized?
Yeah, no, the other side is the drugs are valuable.
So why are they not accessible? Why are Nigerians not being able to?
No, the thing is,
in the
we need to
rural
understand,
areas?
for you to access drugs, you need to understand how you work. So first you need to test people. You need to go and find those people because they are not anywhere in the street.
Okay.
Some are in the farm, some are in the hospital, some are in the school, some are somewhere. So you need to go and test them. That's why we first of all say the first goal is that we must make available 90% of Nigerians must be tested.
Okay.
That is the first goal we have set
Okay.
from the United Nations to Nigerian government. 90% of 170 million is 160 something million. We must be tested. Out of that 160 million we want to be tested, do you know what we are testing every year? 11 million. So we have a huge gap. That's why we are not finding these people. So the first case is that when you get these 90 people, these remaining 2 million people, we are saying out of that 168, 2 million of them are positive. So you need to find them. Once you find them, we're able to put them on treatment.
Okay, so
But
the
we want to
treatments,
put
the
them on
treatments
treatment.
are
Yes.
available. It's just not finding
but
the people.
we want to put them on treatment with our government resources, no longer
okay.
with foreign donors.
Yeah,
So that's what we're saying. And for that to happen, you have to manufacture ARV locally that we use to put them on treatment. If that doesn't happen, you still have to depend on the foreign donors to do that.
All right. So, Walter, how would you generally assess government involvement in the plight of people living with HIV and AIDS in Nigeria?
Yeah, fine. It's been 2 ways. Government involvement has not been as needed,
Okay.
and has not been as expected. So I will go with statistics because everything we do drives with statistics. So first is that there is a 1,058,000 people on treatment in Nigeria.
Okay.
Out of the 1,058,000 people on treatment in Nigeria, PEPFAR contribute to 800 and something thousand, which is foreign, US government.
US government.
The Global Fund contributes 150,000, which is Geneva and the whole world. Nigerian government contributes 58,000.
Oh,
That
okay.
is 5%.
It's just 5%.
So if you want to assess how has the government supported or contributed, that is how. Then in terms of the enabling environment, what we are really asking the government to do, if you do not have the resources, which we believe we have, create the enabling environment, put the structures in place, reposition the health systems to be able to provide effective services. Do not discriminate. Do not stigmatize, because once you do this, these people will go into hiding. I want to leave, even if this is the only thing I'm able to share with us here, I want to share with you here that even all of us in the FCT here, we are at risk. How are we at risk? We have those that work in the Federal Secretariat and work in offices like this and many other tush offices who have cleaners and who have secretaries that live in Pape. Pape prevalence as we speak now is 7.8%. That is higher than any national average anywhere. These secretaries go back in Pape and all these suburbs, Nyanya and the rest, they have unprotected sex. They carry the virus because it's not written in the face. They come into the offices. A lot of sex happens between the boss and the secretaries in the offices. They infect the bosses. The bosses go back and infect their wives. Their wives infect their boyfriends. Their boyfriends infect. So we have chains of people where because annually, right here as we speak, we still have more than 250,000 people being infected every year. We need to put that. So you get to see that the infection rate continues because it's not written on the face. So we will need to find a way for everybody to put their effort. Most importantly, the government needs to stand up to what it should be doing and do it appropriately. That's why we're saying for this year, we are, as much as we're looking at making it happen, we're looking at it in the context of make it happen by being transparent. Make it happen by being accountable, and make it happen by encouraging or liaising with partnerships. Stop. Transparency, accountability, and partnership. That's for us, civil society, what we're asking everyone to do. At the National Council of State, which involve all the governors, they have committed to putting between 0 to 1%, 0.5 to 1% of their state budget to HIV/AIDS response. We want to see that happen. The president has said, I will put 50,000 people on treatment. We want to see that happen. We don't want to come here next year and be saying we are still looking for them. We want to see them happen. That's all we're asking to happen, and that's what we're asking the government to do.
All right. Do you have anything to add to what he just said?
So,
do you have anything to add or concord to?
Just to say that we should not wait for next 365 days to talk about HIV. It's an ongoing process. We should be able to walk, pause, reflect, walk, pause, reflect in the fight against HIV and AIDS. We should understand that, just as I said, that I want to, at this point, say this, that the religious leaders play a very key role in the fight against HIV and AIDS. Let me give you a typical example. A lot of our patients that are dying today are stopping treatment because some religious leaders are saying they have miracles to offer. I'm telling you because I work in a large facility, a very large facility where I see HIV patients every day of my life. So I know what I'm talking about. I have a real picture of what HIV is. I have seen people die from preventable deaths. And I think that we should carry our 2018 advocacy to these same people, because we live in a country that is very religious. People stop their medications, people do things because... So the religious leader has a major role, and we call on them to please join hands. The mistakes they make, because they in their attitude, they are actually fueling the issue of stigma and discrimination. If a religious leader insists, for instance, that you do HIV testing as a requisite for marriage, he is ignorant of the 2014 anti-discriminatory law. You understand? In fact, some of this type videos say they will not, even you do the test, if I come with my wife to be, they won't even show you the results. They will take it to the head pastor and he reflects on it. That is against it. So they need to change this. A lot of people who know, because HIV sexual discordant relationship is a relationship between one who is positive and negative. It's a healthy relationship. But if I'm a very important member of my church, I don't want my pastor to know, because he does not need to know. But my wife needs to know. All the pastor's business is to ensure that my wife knows. Are you sure you done your test? Are you very sure? Both of you sign that you know your status. You don't need to know. Not preventing them. So people don't even do this, go to church again. That is something they need to bring the advocacy to them. They also have a role to play in scaling up HIV testing. Let me tell you, if I have a church and I call all pregnant women to come out for prayers, and after praying to them, I tell them to please make Sister Onye after service, and Sister Onye tells them it's good to do HIV test too. It's good to, but you could be positive. Those women will listen more. HIV test to be scaled up in those facilities. So we need to use what we have, leverage on what we have. The second thing about stigma and discrimination, I said every Nigerian likes to watch a movie. In the early 80s, when HIV came in, when you see an HIV positive and you see somebody that is dying, even if you are talking to somebody behind the screen, they'll be talking one-one. Or a person live. They make it look so bad. But everybody watch these movies. And I tell you, if our orientation agency forgets about placards, but going to Nigeria and make me, if I'm talking like this and they say I'm a HIV patient, this person can even talk like this and it's HIV. So we want to see orientation changing from the leverage on what we have, which will change the face of HIV. Majority of our clients in facilities are living in healthy relationships which are sexual discordant. So we need to reorient Nigerians on the issue. Just recently, a very important pastor in FCT called me. You know what they call the Truecaller app? If you say my name, it is what it will show as a Truecaller app. And the name of the pastor was Pastor blah 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 HIV. Somebody has saved his number somewhere as HIV. That is the stigma. Stigma is a label. Discrimination is an action. You have labeled people. So we should stop labeling people. I am not HIV. It's not a certificate I have acquired, for instance. It is who I am. So we should try to change the orientation of people. Stigma and discrimination would stop. And once stigma and discrimination drops, a lot of people will go and do tests. The religious leaders have a major role. And if everybody keeps their promise to play these two little rules, I tell you by 2030 we'll be talking about, we will be coming on first world, we'll be celebrating our achievements.
All right, thank you. Thank you very much for coming on the news tonight.